Welcome back to the Deep Dive. Today we're tackling a really important mission. We want to clear away some of the historical, fog surrounding fibromyalgia, or FM.
Yeah, that's a good way to put it. Fog.
For just decades, this condition was kind of unfairly pushed aside, wasn't it? Labeled as unexplained pain.
Exactly. And that label did so much damage.
So our deep dive today is based on solid clinical sources: StatPearls, Mayo Clinic, NHS, Cleveland Clinic data, major consensus reports.
Good sources.
And the goal is really to move way past that old skepticism. We're here to explore FM as what the science now clearly shows it is, a profound, measurable neurological disorder.
And that shift in understanding is just crucial. I mean, the biggest hurdle for everyone, clinicians and patients, was always the lack of that classic, visible inflammation or tissue damage you could point to.
Right. No obvious injury on an X-ray or blood test marker.
Precisely. But the modern science, it shows the problem isn't really in the muscles or joints directly. It's in the central processing, the control room, so to speak. We now understand FM as this chronic pain disorder defined by a fundamental issue with how the central nervous system regulates pain. It's really a disorder of pain regulation itself.
Absolutely. So just to frame this for everyone listening, let's establish the clinical picture.
Yeah.
We're talking about chronic, widespread musculoskeletal pain.
Right.
And the definition is key, lasting over 3 months.
3 months, yeah. That's the minimum threshold.
And it's consistently paired with this trio of really tough non-pain symptoms: debilitating fatigue,
Crushing fatigue, yeah.
pervasive cognitive issues that fibro-fog people talk about,
The brain fog. Very real.
and severe sleep problems, specifically that non-restorative sleep, waking up feeling like you haven't slept at all.
Yeah. And if there's one core insight, one aha moment we hope you take away today, it's this. Fibromyalgia is the classic example of central sensitization.
Okay, let's unpack that term a bit. Central sensitization.
Think of it like the body's internal pain volume knob. In FM, it's like that knob is stuck, turned way, way too high, permanently.
So everything feels louder, pain-wise.
Exactly. And this amplification, this loudness, it doesn't need actual damage out in the tissues to happen. It comes from
Typically hitting during the reproductive and early middle-aged years, say 20 to 55.
That's the peak window, yeah. And the numbers show females are diagnosed at least twice as often as males, maybe even more.
And it holds that unfortunate title, doesn't it? The single leading cause of generalized musculoskeletal pain in women.
It does. So when a female patient comes in, especially in that age range, complaining of diffuse chronic aches, FM has to be high on your list of possibilities right away.
And we should also touch on the fact that this isn't just an adult condition.
That's a really important point. Our sources mention juvenile primary fibromyalgia syndrome, JPFS.
JPFS, right?
It's definitely less studied than the adult form, but it's out there. It affects somewhere between 1% and maybe up to 6% of school-aged kids and adolescents.
1 to 6%. That's not insignificant.
Not at all. And that gender difference we see in adults, it's even more pronounced in kids. Nearly 84% of JPFS cases are female.
84%.
Wow. And diagnosis often happens around, say, age 15. So the pain, the functional decline, it can start incredibly early for these young people.
That really underlines the long-term chronic nature of this. Okay, let's dive into the core symptoms, the 4 main clusters that really define what a patient goes through, starting with the big one: widespread pain. What does it actually feel like clinically?
It's typically described as this chronic, nagging, dull ache, like a baseline level of discomfort that it never really goes away completely. Patients often use phrases exactly like, "I hurt all over," or that very specific one you hear a lot, "I feel like I always have the flu," that kind of deep, body-wide ache.
And to meet the current diagnostic criteria, the 2016 ACR ones, this pain needs to be chronic, right? So 3 months or more.
Minimum 3 months, yes. And it has to be distributed widely. The criteria specify at least 4 out of 5 defined body regions.
Okay, 4 out of 5 regions. And what makes this pain particularly difficult, almost insidious, is how it reacts to activity, right?
Exactly. It's this double-edged sword. Minimal physical activity can flare it up badly, which makes recommending exercise really tricky.
Yeah, a real challenge.
But then prolonged inactivity also makes it worse. So sitting still for too long is bad, moving too much is bad.
We hear about severe morning stiffness all the time, lasting for hours sometimes.
Very common. And we really need to stress this for listeners. Even if a patient reports feeling like their joints are painful or even subjectively swollen, The clinical exam, the imaging, it confirms there's no actual synovitis, no real structural joint damage happening. The sensation is absolutely real, but the source of the problem is centralized in the nervous system.
Got it. Okay, moving to that second pillar, fatigue. And this isn't just being tired.
Oh, absolutely not. This is profound. Debilitating exhaustion. Patients often compare it to that completely draining fatigue you get during a really bad flu or mono.
Right. Systemic exhaustion.
Yeah. And just like the pain, this fatigue is made worse both by exertion and by rest. It's this awful catch-22 where the patient just can't seem to recharge their batteries no matter what they do or don't do.
And that lack of recovery, that inability to recharge, it feeds right into the third major piece, sleep disturbances.
Yes. Patients will often say, I slept for 8 hours, 9 hours even, but I woke up feeling like I ran a marathon.
That's the non-restorative sleep we talk about.
Exactly. That specific label is key, and the research here is really compelling.
How so?
Well, the sources point to a specific pattern often seen in sleep studies of FM patients. It's called phasic alpha sleep intrusion.
Alpha intrusion into deep sleep.
Exactly. Alpha waves, which are normally associated with lighter wakefulness or very light sleep, they intrude into the delta wave sleep, which is our deep restorative sleep stage. It fragments the sleep architecture.
So the brain isn't getting that deep rest it needs.
Precisely. And what's fascinating, maybe even critical, is the relationship between this poor sleep and the pain. Non-restorative sleep is actually the strongest predictor of widespread pain intensity.
Stronger than other factors.
Stronger than many others. And some studies looking long-term even suggest that the sleep disruption might actually start before the chronic pain really sets in.
Wow, so sleep issues could be an early trigger, not just a consequence.
It's a strong possibility. It positions this messed up sleep cycle as potentially an inciting factor, driving the pain system haywire, which of course creates this vicious self-feeding loop. Bad sleep makes pain worse, pain makes sleep worse.
Around and around it goes.
Yeah, it's relentless.
And that exhausting loop of chronic pain and fatigue, it directly impacts the final symptom cluster, cognitive dysfunction, the fibrofog or brain fog. What specific problems are we seeing there?
It's a measurable hit to executive function,
Yep.
Big time. Patients really struggle with concentration, with staying focused on complex tasks. Memory problems are very common, especially working memory, holding information in mind to use it, and learning new things.
Okay.
And perhaps most noticeably, they experience this distinct slowing of processing speed. It's like their brain's CPU is just running slower.
Like trying to run modern software on an old, underpowered computer.
That's a great analogy, actually, and it's incredibly impairing. It leads to difficulties with mentally demanding work, problems at their jobs, and understandably, a lot of anxiety about their cognitive abilities.
So these four pillars, the widespread pain, the crushing fatigue, the non-restorative sleep, and this cognitive fog, they really form the core picture we need to recognize for diagnosis and treatment.
Absolutely, that's the constellation.
Okay, let's make that leap now from how it feels to the patient, the clinical side, into the objective neurological reality. This classification of FM is a disorder of central sensitization. This is where the science really backs up the patient's experience, isn't it?
It absolutely is, and this is where we need to hammer home. The cause isn't inflammation, like in arthritis, but the effects are profoundly physical, neurologically driven.
So the pain signals themselves are getting amplified within the central nervous system.
Exactly. Influenced by a mix of things, genetic predispositions, definitely. Environmental triggers play a role.
Like major physical trauma.
Or infections.
Yes. Things like significant injuries, surgeries, or even severe infections, Lyme disease, Epstein-Barr virus have been linked as potential triggers in susceptible individuals. And underlying all that are fundamental changes in neurobiology.
So to really get central sensitization, we need to picture the nerve cells, the neurons involved in pain transmission. They become, persistently overactive.
Hyperexcitable is the term we use. They're essentially stuck in the on position, or they fire way too easily. They misinterpret signals, turning minor everyday input into significant pain signals.
Okay, so if this is a real physiological state, how can we actually demonstrate or measure this hypersensitivity in people? Well, clinically, we see it in the ultric perception. The patient feels pain from stimuli that wouldn't normally hurt. That's called allodynia, like light touch feeling painful.
Right.
Or they feel much more pain than expected from a mildly painful stimulus, that's hyperalgesia. But the really compelling objective laboratory finding is something called temporal summation of pain.
Temporal summation. Okay, explain that for us, because you said it's key evidence.
Right. Temporal summation, sometimes called wind-up, happens mostly in the spinal cord. Now, in a healthy person, if you apply a quick series of short, sharp, mildly painful stimuli like repetitive brief pinpricks, the pain intensity they feel should kind of level off, it should plateau, the system adapts.
Makes sense.
But in someone with FM, that same rapid, repetitive stimulation causes a dramatically higher and continuously escalating perception of pain. The pain just keeps climbing with each pulse.
So it's like the system can't put the brakes on.
Exactly. It's direct physical proof that the central nervous system can't effectively dampen or inhibit those incoming pain signals. It points right to a measurable deficiency in the body's own built-in pain relief systems, the endogenous analgesic systems, like our natural opioids.
That mechanism, faulty wiring, essentially is powerful.
But what really takes this to another level is the neuroimaging data, the brain scans. Structural MRI findings have shown actual physical changes in the brains of people with FM. This is where it gets fascinating. What are these scans showing?
The evidence is pretty startling, actually, and it hints at something maybe more neurodegenerative than we previously thought. We consistently see reduced total gray matter volume in FM patients compared to healthy controls.
Less gray matter, where specifically?
The loss seems most pronounced in really critical brain areas, the anterior cingulate cortex and the prefrontal cortex.
And those areas are crucial for? Oh, hugely important. They're not just involved in processing the sensory aspect of pain, they're vital for executive functions planning, decision-making, for emotional regulation, and critically, for the brain's ability to send signals down the spinal cord to inhibit pain, the descending pain modulation pathways.
So the gray matter loss isn't just random, it's hitting the very command centers that help us cope with pain and manage our thoughts and emotions. Does this structural loss line up with the symptoms, like the fibro fog?
It connects directly. The prefrontal cortex is the seat of those executive functions. Seeing measurable thinning or atrophy there helps explain the struggles with memory, focus, and that slower processing speed we talked about. When you see these structural changes, it implies a real functional cost. But what's perhaps most concerning is the rate of this change. Some studies suggest that people with fibromyalgia show signs of premature brain aging.
Premature aging? How so?
They exhibit potentially a threefold increase in the amount of age-associated gray matter loss compared to healthy people of the same age.
A 3 times faster rate of gray matter loss linked to age. That's alarming.
It is, and it seems to correlate with how long they've had the disease. It really reinforces that FM isn't static. The brain structure itself might be changing over time in response to this condition.
That's a huge finding, a significant long-term risk.
Absolutely. And beyond just volume loss, we also see changes in functional connectivity, how different brain regions are talking to each other, especially within key brain hubs that are supposed to integrate information from various networks. The brain seems to be rewiring itself, often in less efficient ways, under this constant barrage of amplified signals.
Okay, so we have structural changes. Let's move to the chemical messengers, the neurotransmitters. What imbalances are driving this hyperexcitable state? What's going on with the neurochemical cocktail?
It really seems to boil down to an imbalance: too much excitation, not enough inhibition. So on the excitation side, we find evidence of elevated levels of glutamate. That's the brain's main go signal, the primary excitatory neurotransmitter.
And where is this excess glutamate found?
It seems particularly concentrated in areas like the right posterior insula. This is a really important region for processing pain and internal body sensations. And higher glutamate levels there correlate directly with lower pain thresholds. The brain is basically overstimulated.
So if glutamate is the accelerator pedal stuck down, is the brain also low on brake fluid? Is inhibition faulty?
That seems to be exactly the case. We see signs of compromised inhibitory control. This involves altered GABAergic neurotransmission. GABA is the main stop signal, the primary inhibitory neurotransmitter, and its calming action appears reduced. And also, altered dopaminergic pathways seem involved.
Dopamine, how does that play into pain?
Dopamine is involved in motivation, reward, but also in anticipating and modulating stressful experiences, including pain. Functional MRI studies show that areas like the ventral tegmental area, which is rich in dopamine, show reduced activation in FM patients when they're anticipating pain.
So if the system isn't properly gearing up to inhibit the pain it expects,
the pain signal hits much harder when it arrives. The preparation, the modulation is faulty.
Interesting. And beyond those main players, you mentioned a specific metabolite earlier in inositol. Why is that one flagged?
Right, inositol, it's a precursor for secondary messenger systems within cells, kind of indicating metabolic activity or stress. And elevated levels of inositol have been found pretty reliably in specific brain regions in FM patients, particularly the right amygdala and the right thalamus.
Amygdala and thalamus.
Yeah.
Key emotion and sensory relay centers.
Exactly. Deeply tied into emotional processing, fear responses, and integrating sensory information. And these higher inositol levels, they correlate strongly with increased pain scores, higher fatigue levels, and more severe depression symptoms.
So it provides a kind of chemical link tying together the physical pain, the exhaustion, and the mood component.
Precisely. It bridges those core symptom domains at a biochemical level.
Okay, let's pull back a bit now and look at the broader system, the body's stress response. Autonomic dysfunction. How does that constant threat state feed into this centralized pain picture?
Well, chronic pain itself acts as a major chronic stressor, right? And this pushes the autonomic nervous system, the system controlling automatic functions like heart rate, digestion, breathing into a state of overdrive.
The fight or flight system running constantly.
Pretty much. A very consistent finding in FM research is reduced heart rate variability, or HRV.
Explain HRV briefly.
HRV measures the natural variation in time between heartbeats. Healthy, adaptable systems have higher variability. Low HRV is a classic sign of heightened sympathetic nervous system activity, that fight or flight branch being dominant. It signals a constant state of physiological stress and hypervigilance.
And we see the physical signs of that sympathetic overdrive in the clinic, don't we?
Absolutely. Patients report things like changes in skin conductance, clammy hands, excessive sweating. They often experience orthostatic hypotension, feeling dizzy or faint when standing up quickly. Raynaud phenomenon is common fingers and toes turning white or blue in response to cold or stress, and palpitations, feeling like their heart is racing or skipping beats. These are all downstream effects of that autonomic imbalance.
Now, what about the HPA axis, the hypothalamic pituitary adrenal axis, the main hormonal stress pathway involving cortisol? Is that clearly dysregulated too?
That's where it gets more complex and honestly a bit contradictory in the research.
Yep.
Yeah. While early theories suggested maybe FM involved low cortisol, kind of an adrenal exhaustion picture, the larger body of evidence now shows really mixed findings. Some studies find low cortisol, some find normal levels, some even find high levels or blunted responses to stress tests.
So no clear pattern like with HRV.
Not as clear-cut, no. It seems the HPA axis involvement is much more variable between individuals. It confirms that while the nervous system's immediate stress response, the sympathetic branch measured by HRV, is clearly ramped up, the hormonal stress axis, HP response, is more complex and probably influenced by many other factors in FM. It's still an active area of research.
Okay, that's important nuance. Now, one more piece of this puzzle. If the main problem is central, in the brain and spinal cord, how do we explain symptoms that seem peripheral, out in the limbs? Is there evidence the central issue can cause problems out there too?
There is, and it's a really interesting development. Many FM patients report symptoms that sound exactly like small fiber neuropathy, or SFN.
Like what kind of symptoms?
Burning pain, pins and needles, numbness, tingling sensations, often in that classic stocking and glove distribution feet and lower legs, hands, and forearms.
And can we actually prove there's nerve damage there?
In some cases, yes. Skin biopsies can be done, looking at the density of the tiny nerve fibers in the epidermis. And a subset of FM patients show a confirmed reduction in intraepidermal nerve fiber density, which is the objective diagnostic marker for SFN.
So the central problem might actually be leading to peripheral nerve changes. How'd that work?
The leading hypothesis is something like this. The constant barrage of amplified signals from the periphery, combined with potentially neurotoxic substances like excess glutamate circulating within the central nervous system, might over time either damage or cause retraction of these small sensory nerve endings out in the skin.
Wow. So the central amplification loop could effectively burn out or prune back the peripheral sensors.
That's the idea being explored. It's a compelling example of how a primarily centralized disorder can eventually manifest with measurable, localized pathology in the periphery. And it definitely complicates the picture both for diagnosis and for finding treatments that target all aspects.
It really highlights the complexity. Okay, let's shift gears slightly. One of the biggest challenges in actually managing FM day to day is that it so rarely travels alone.
Oh, absolutely. That central hypersensitivity seems to act almost like a magnet, drawing in a whole constellation of other symptoms and conditions. It makes the patient's overall burden so much heavier.
It's like the volume is turned up not just for pain, but for other sensations too.
That's a great way to think about it. It's a system-wide dysregulation. So when sensory input is amplified, it doesn't just affect muscles and joints, it hits the internal organs too, the viscera, which leads to huge overlap with other functional syndromes.
Okay, like in the gut, for instance, what overlaps do we see there?
Extremely high rates of co-occurrence with irritable bowel syndrome, IBS.
Makes sense. IBS also involves that visceral hypersensitivity.
Exactly. Same underlying mechanism, just manifesting as chronic abdominal pain, bloating, altered bowel habits. Gastroesophageal reflux disease, GERD, or chronic heartburn is also very common.
And in the genitourinary system.
Similar picture. Urinary urgency, frequency, sometimes feeling like they constantly have to go. This can sometimes meet criteria for painful bladder syndrome or interstitial cystitis again, likely related to that centralized amplification affecting the sensory nerves of the bladder and pelvic floor.
Okay. And moving up the body, headaches seem almost universal in FM.
It feels that way sometimes. Studies suggest nearly half, maybe even more, of FM patients struggle with frequent headaches.
Okay.
The whole spectrum, really. Chronic tension headaches are very common, but also debilitating migraines, even cluster headaches in some cases.
Oh.
We also see temporomandibular joint disorder, TMJ, causing chronic jaw pain, facial pain, clicking, or locking. It suggests that pain map really extends up into the head and face.
Any other sensory issues?
Yeah, things like dry eyes, sometimes diagnosed as dry eye syndrome, are reported frequently, and occasionally some patients report unexplained hearing loss or tinnitus, suggesting maybe broader sensory processing difficulties beyond just pain.
Now let's talk about the elephant in the room, the psychiatric comorbidities. Given everything we've discussed about brain changes and central nervous system dysregulation, the link to mental health seems unavoidable and critical for treatment.
Absolutely critical. The statistics are quite stark. Somewhere between 30% and 50% of FM patients also have a diagnosable major depressive disorder or a generalized anxiety disorder.
30 to 50%, that's huge.
And those numbers are likely even higher if you include people with significant symptoms that don't quite meet full diagnostic criteria.
Are there other mental health links?
Yes. Systematic reviews also show a higher prevalence of more complex conditions like bipolar disorder, severe panic disorder, and a really strong link with post-traumatic stress disorder, PTSD.
PTSD. Does that tie back to those environmental triggers we mentioned, like trauma?
It often does seem to. A history of significant physical or emotional trauma is a known risk factor for developing FM, and the PTSD symptoms can significantly overlap and worsen the FM picture.
And it's important to stress, these mood disorders aren't just a reaction to being in pain, right? They likely share some underlying biology.
That's exactly right. They share neurobiological pathways. The same brain regions involved in central sensitization, the limbic system, the prefrontal cortex, are also deeply involved in mood regulation. So the depression can actively worsen the pain perception, and the chronic pain can worsen the depression. It's a true vicious cycle, biochemically intertwined.
A feedback loop.
Totally. And this also highlights why we need to pay attention to certain personality traits or coping styles that are more common or perhaps exacerbated in FM, things like pain catastrophizing.
Meaning?
That's the tendency to ruminate on the pain, magnify the threat of it, and feel helpless about it. Basically, focusing excessively on the worst possible outcomes.
Okay.
And also alexithymia.
Alexithymia.
Yeah, that's a difficulty in identifying and describing one's own emotions. People struggle to put words to how they're feeling. Recognizing these factors catastrophizing, alexithymia is crucial because they are major targets for non-drug treatments like cognitive behavioral therapy.
Right, which we'll definitely get to. But first, let's talk diagnosis. Historically, getting an FM diagnosis was often a long, frustrating journey for patients. Years, multiple doctors, mainly because it's a diagnosis of exclusion, isn't it? There's no single blood test that says, yes, it's fibromyalgia.
That's the absolute crux of it. The diagnosis is purely clinical. It's based on the patient's story, their reported symptoms, and a really thorough history and physical exam.
But tests are still needed initially.
Oh, absolutely essential. But not to diagnose FM. Initial lab work things like a complete blood count, CBC, inflammatory markers like CRP and ESR, thyroid stimulating hormone, TSH, maybe vitamin D levels, they're critical to rule out other conditions that can mimic FM very closely.
Like what sort of mimics?
Things like hypothyroidism, which can cause fatigue and aches, certain autoimmune diseases like lupus, SLE, or polymyalgia rheumatica, muscle inflammation conditions like myositis, or even severe nutritional deficiencies. You have to exclude those possibilities first.
And what about those more specific rheumatology tests like rheumatoid factor or ANA, anti-nuclear antibodies? Should those be routine?
The clear consensus among rheumatologists now is no, not unless the patient has specific signs or symptoms on exam, like clear joint swelling, rashes, specific organ involvement that strongly suggest an inflammatory rheumatic disease like RA or lupus.
Why not just order them anyway?
Because ordering them without a clear clinical reason often leads to false positives or ambiguous results that just cause confusion, anxiety, unnecessary referrals, and delay getting the patient started on appropriate treatment for what is likely a centralized pain syndrome. It muddies the waters.
Okay, so the ability to make this clinical diagnosis confidently has improved a lot with the evolution of the official diagnostic criteria. We should probably touch on that history briefly. The old 1990 ACR criteria.
Right, the 1990 criteria were the standard for a long time, but we need to understand why we moved away from them.
They were all about the physical exam, weren't they? The tender points.
Exactly. They focused almost entirely on the tender point exam. The examiner had to press on 18 specific soft tissue sites, and the diagnosis required tenderness, the patient reporting pain on palpation in at least 11 of those 18 spots.
Seems objective in theory.
In theory, yes. But in practice, standardization was a huge problem. How hard did the examiner press? It varied. And more importantly, that system completely ignored the other core symptoms, the fatigue, the fog, the sleep issues. It felt incomplete, sometimes arbitrary. A patient could miss the diagnosis by one tender point but still be severely impaired.
Which led to the need for a more comprehensive approach, leading eventually to the current 2016 ACR revised criteria. How do these work differently? How do they capture the whole picture better?
The big shift in the 2010 criteria, refined in 2016, was moving away from the examiner-dependent tender points altogether. Instead, the focus shifted to quantifying the patient's reported symptom breadth and severity.
Okay, how was that quantified?
It uses two main scoring tools. First is the Widespread Pain Index, WPI. This is simply a count of the number of body regions out of 19 defined areas where the patient has experienced pain in the last week.
Okay, so breadth of pain.
Breadth, exactly. And the second part is the Symptom Severity SS score, and this is where the non-pain symptoms finally get formally included.
That seems crucial. How does the SS score work?
It measures the severity, rated by the patient on a scale of 0 to 3, for 3 key symptoms: fatigue, waking unrefreshed, non-restorative sleep, and cognitive symptoms, fibrofog.
Okay.
It also adds points based on the presence of other somatic symptoms like headaches, abdominal pain, depression, etc. You combine the WPI score and the SS score.
And there's a threshold to meet.
Yes. The key diagnostic requirement is having generalized pain defined now as pain in at least 4 out of 5 large body regions. They simplified the counting. And importantly, this specifically excludes pain localized only to the jaw, chest, or abdomen.
4 out of 5 regions, got it.
And these symptoms need to have been present at a similar level for at least 3 months. This approach does a much better job of capturing the patient's total experience, their functional limitations, not just where they hurt when poked.
So the criteria give us a solid framework, a more reliable way to diagnose. But we still need to emphasize they're a tool, right? They don't replace good clinical judgment.
Absolutely not. Thorough history, careful exam to rule out those mimics, understanding the individual patient's context, that remains paramount. The criteria guide us, but they don't make the diagnosis on their own, especially differentiating FM from more localized pain issues.
Okay. So once the diagnosis is established, let's talk management. The philosophy here has to be holistic, multidisciplinary. Given everything we know about central sensitization, the goals are symptom relief, yes, but also really empowering the patient, boosting their self-efficacy.
That's the core, empowering self-management for a chronic condition that isn't, degenerative in the traditional sense, but profoundly impacts function.
And that starts right at the beginning, doesn't it, with education and validation.
Crucially, the first step is often just reassuring the patient. Yes, your pain is real. It's not in your head, it's in your nervous system. It's physiologically measurable. It's due to the centralized amplification, not tissue damage. That validation alone can be therapeutic.
And setting realistic expectations is vital too.
Absolutely. We have to be honest. There's no magic bullet, no cure right now. Therapy aims to significantly improve symptoms, improve function, manage flare-ups, but symptoms will fluctuate. That's normal, it's expected. Understanding that helps prevent despair during bad patches.
Okay. Given that FM seems to be this disorder of, neurological regulation and maybe lifestyle interaction, The foundation of treatment really has to be non-pharmacological, right?
Without a doubt. If a patient could only consistently do two things, it should probably be exercise and some form of cognitive behavioral therapy. These are the cornerstones.
Let's start with exercise physical activity. The evidence for its benefit is strong, but it's so tricky to implement.
It is strong. It helps with pain, sleep, fatigue, mood. The recommendation is generally low-impact aerobic exercise. Things like walking, swimming, water aerobics, biking, aiming for maybe 30 minutes 3 times a week. And this is a huge but.
You have to warn them about the start.
You absolutely have to. Starting an exercise program, even gently, will very likely increase their pain and fatigue initially.
That's such a huge barrier to adherence.
Yeah.
They feel worse, so they stop.
Exactly, which is why intensive counseling on pacing is non-negotiable. The mantra is start low, go slow.
What does that look like practically?
It might mean starting with just 5 minutes of slow walking. Seriously, just 5 minutes. If they tolerate that without a major flare-up for a week or two, then maybe increase to 6 minutes. Not doubling it, just tiny increments. Using time-based goals, not walk until it hurts goals.
Time-based, not pain-based. That's key.
It prevents that boom and bust cycle where they overdo it on a good day and then crash for 3 days, reinforcing the idea that exercise is harmful. It takes patience, but it works.
Okay. And the second cornerstone, cognitive behavioral therapy, CBT. This targets the psychological aspects, the catastrophizing, anxiety, the fog.
Right, and CBT isn't just talking about your problems, it's a structured, skill-based therapy. It's proven effective in FM for reducing pain intensity, improving sleep, reducing anxiety and depression.
What are the specific goals of CBT and FM?
It works on identifying and challenging those unhelpful thought patterns, especially the pain catastrophizing we talked about. It teaches better coping skills for dealing with flare-ups and limitations. And it helps modify behaviors that might be unintentionally worsening the pain cycle, like activity avoidance or poor sleep habits.
Access can be an issue, though, finding therapists skilled in CBT for chronic pain.
It can be, which is why we should definitely encourage patients to explore options like online CBT programs, telephone-based therapy, or even guided self-help workbooks based on CBT principles. These can be very effective accessibility solutions.
Good point. And we absolutely must address sleep hygiene, given that direct link between poor sleep and worse pain. What are the essentials there?
Consistency, consistency, consistency. Same bedtime, same wake-up time, 7 days a week, as much as possible.
Even on weekends?
Even on weekends, unfortunately. To keep that internal clock stable, the sleep environment needs to be optimized. Dark, quiet, cool.
And behaviors around bedtime?
Crucial. No caffeine after lunch. Limit alcohol, especially in the evening. Avoid large meals right before bed. And the big one these days, restrict screens, phones, tablets, computers for at least 30 to 60 minutes before trying to sleep. The blue light messes with melatonin.
And we also need to be vigilant for other sleep disorders, right?
Yes. Things like obstructive sleep apnea or restless leg syndrome are actually quite common in FM patients too. If those are present, they need to be diagnosed and treated aggressively because they will completely sabotage any chance of restorative sleep, no matter how good the hygiene is.
Okay, so exercise, CBT, sleep hygiene. Those are the non-drug foundations. Now let's talk pharmacological interventions. We need to be clear here. Meds are adjuncts. They help some people, but they aren't cures.
That's the perfect way to frame it. Medications offer moderate relief for maybe about half of patients. We often aim for about a 30% reduction in symptoms, which can be meaningful, but it's rarely complete relief. And the choice of drug has to be highly tailored to the patient's main symptom drivers.
So how do we tailor? Let's say the biggest issues are widespread pain and really bad sleep. Where do we lean?
In that case, we often consider the alpha-2 ligands. These are drugs like pregabalin, Lyrica, or gabapentin, Neurontin.
How do they work?
They work by binding to a specific part of voltage-gated calcium channels in the nervous system, the alpha-2 delta subunit. By doing this, they effectively reduce the release of excitatory neurotransmitters, like that glutamate we talked about, from hyperexcitable nerve endings. They essentially help calm the storm, reduce the excessive firing.
Okay, so they dampen the hyperexcitability.
Yeah.
Now, what if the patient also has significant fatigue or maybe clear coexisting depression or anxiety?
Then we might shift towards drugs that boost the body's own pain inhibition pathways. That leads us to the serotonin norepinephrine reuptake inhibitors, or SNRIs.
Like duloxetine or milnacipran?
Exactly. Duloxetine Cymbalta and milnacipran Savella are both FDA approved for FM. Duloxetine, for example, is usually started in the morning. It increases levels of both serotonin, which helps with mood, and norepinephrine. And norepinephrine is key for strengthening those descending pain inhibition pathways that run from the brainstem down the spinal cord. It helps the brain turn the pain volume down more effectively.
There's a dual action there.
Right, helping mood and boosting natural pain control.
And what about those older drugs, the tricyclics? Are they still used?
Yes, definitely, especially when diffuse pain and particularly sleep onset or maintenance are the dominant problems. We're talking about the tricyclic antidepressants, TCAs, but used at much lower doses than for depression.
Like amitriptyline.
Amitriptyline is the classic example. Cyclobenzaprine, Flexeril, which is structurally similar, is also used. They're usually given as a small dose before bedtime. The goal isn't really antidepressant effect at these doses, it's leveraging their potent effects on promoting deeper sleep stages and their complex actions on central pain modulation pathways.
Lower doses to minimize side effects too, presumably.
Exactly. Minimize things like daytime sedation, dry mouth, constipation that you see at higher antidepressant doses.
Okay, so we have these main classes, but just as important is what we should not be using, right?
Right.
The literature seems pretty unanimous here.
Extremely unanimous and critically important. Despite how severe the pain can be, standard painkillers like NSAIDs, ibuprofen, naproxen, and acetaminophen, Tylenol, are generally not effective for the centralized pain of fibromyalgia. They target peripheral inflammation, which isn't the main driver here.
And what about opioids?
Standard opioids, drugs like codeine, hydrocodone, oxycodone, are also strongly not recommended for long-term FM management.
Why not? Patients are in real pain.
They are, but opioids haven't shown good long-term efficacy, specifically for FM pain mechanisms. And they come with a huge burden of risks. Tolerance, dependence, addiction, opioid-induced hyperalgesia, where they can actually worsen pain over time, sedation, constipation, cognitive issues. The risks far outweigh the limited benefits in the specific condition. Using them is generally treating a symptom without addressing the underlying central problem, and it often leads to poorer function long-term.
That's a really clear message.
Yeah.
Okay, but are there other, maybe less conventional or off-label options that show some promise? What about low-dose naltrexone, LDN? We hear more about that lately.
LDN is definitely gaining traction as an off-label option. It's naltrexone, an opioid receptor blocker, but used at a tiny fraction of the dose used for addiction treatment, typically around 4.5 milligrams, sometimes less, usually taken at bedtime.
How is blocking opioid receptors supposed to help pain?
It sounds paradoxical, right? The theory is that this very low dose causes a brief, temporary blockade of opioid receptors overnight. The body then responds to this blockade by trying to compensate it, upregulates its own production of endogenous opioids, endorphins, and increases the sensitivity of the opioid receptors.
So it kind of jumpstarts the body's own pain relief system.
That's the main hypothesis. There's also evidence it might modulate immune cells in the brain called microglia, reducing neuroinflammation, which could also contribute to central sensitization. It's an intriguing approach, trying to leverage the body's own systems.
Interesting. What about directly stimulating the nervous system, neuromodulation?
Yeah, that's another growing area. Things like high-intensity transcutaneous electrical nerve stimulation, TENS, applied over painful areas, and also non-invasive brain stimulation techniques like transcranial magnetic stimulation, TMS, or transcranial direct current stimulation, TDCS.
How do those work?
They use magnetic pulses, TMS, or weak electrical currents, TDCS, applied to the scalp to try and directly modulate the activity in specific brain regions involved in pain processing or fatigue perception, essentially trying to retune the hyperexcitable circuits. Early results are promising for reducing pain and fatigue in some patients.
Any other complementary therapies with decent evidence?
Acupuncture and massage therapy both show moderate evidence of benefit for pain and stiffness in FM, probably working through a combination of local effects and modulation of central pain pathways. They can be valuable adjuncts as part of a comprehensive plan.
Okay. And finally, briefly, nutrition. Always a hot topic in chronic illness. Any specific diet proven for FM?
No single fibromyalgia diet has emerged with strong proof. However, the link between FM symptoms and body mass index, BMI, is pretty clear.
How so?
Studies show that patients who are classified as overweight or obese often experience significant improvements in pain, fatigue, and depression if they achieve meaningful weight loss, typically defined as 10% or more of their body weight.
Why would weight loss help?
Probably multiple reasons. Less mechanical strain on the body, reduced systemic low-grade inflammation, often associated with obesity, potentially improves sleep apnea, and likely enables increased physical activity. It's a powerful intervention for those it applies to.
Any specific dietary patterns being studied?
Plant-based diets and low FODMA diets, which reduce certain fermentable carbohydrates often problematic in IBS, are areas of active research. They might help some individuals, particularly those with significant overlapping IBS symptoms, by reducing gut inflammation or visceral hypersensitivity, but more research is needed before making broad recommendations.
So this whole picture, the complexity, the need for integrating drugs with intensive behavioral changes, the focus on self-management, really leads to a fascinating point about how we actually deliver chronic care, doesn't it?
It absolutely does, which brings us to the prognosis and looking forward.
Right. So the outlook for FM, it's defined as chronic.
It is. It waxes and wanes. For some people, symptoms can improve significantly with comprehensive management, but for many, it remains a long-term challenge that impacts quality of life and function quite severely. Reported disability rates range pretty widely, but can be anywhere from 10% up to 30% of patients being unable to work.
And we know that certain factors predict a tougher course, a poorer prognosis.
Yes, things we've touched on. Untreated or poorly managed depression or anxiety is a big one. A history of significant trauma or abuse. High levels of that pain catastrophizing we discussed. And ongoing high levels of life stress. These factors really stack the deck against a good outcome if they aren't addressed.
Are there physical complications too?
Yes, indirectly. There's an increased risk of developing metabolic syndrome, likely linked to reduced physical activity levels over time. And tragically, studies do show an elevated risk of accidents, possibly due to fatigue or cognitive fog, and also an increased risk of suicide compared to the general population. It underscores the seriousness of managing the overall burden of the illness.
It really does. And this all leads directly to perhaps the most surprising and maybe most instructive finding in the whole literature about FM outcomes. It's about where patients get their care.
Yes, the tertiary care paradox. It's fascinating.
Tell us about that, the paradox of tertiary care.
Okay, so multiple longitudinal studies following patients over time have consistently found something counterintuitive. Patients whose fibromyalgia is managed exclusively at large, specialized academic tertiary care centers.
The big university hospitals, the expert clinics.
Exactly. Those patients often have a significantly worse long-term prognosis, more pain, worse function, lower quality of life, compared to patients who are primarily managed within well-coordinated community primary care settings.
Wait, hang on. The places with the most specialized knowledge, the top experts, the advanced diagnostics, they produce worse long-term outcomes for FM. How does that even make sense?
It seems counterintuitive, right? But think about what we've emphasized is key for managing FM successfully.
The non-drug stuff. The exercise pacing, the CBT skills, the sleep hygiene, the self-management.
Exactly. For a condition that is so heavily dependent on the patient developing self-efficacy, making significant behavioral changes, and consistently sticking with those non-pharmacological strategies day in and day out, maybe the crucial factor isn't just the depth of specialized pathophysiological knowledge found at the tertiary center.
So what is the crucial factor then?
It seems to be the continuity of care. The ongoing, trusting, collaborative relationship built over time between the patient and their primary care team in the community setting. That continuous support, the regular check-ins, the reinforcement of those challenging lifestyle changes, that seems to be what actually enables patients to sustain the hard work needed for long-term improvement.
Wow. So it fundamentally reframes what expert care means for chronic conditions like this. It's not just about knowing the science, it's about the process of care delivery, the relationship, the long-term coaching and support.
That appears to be the powerful message here. For a centralized pain disorder, where success hinges on the patient actively participating in turning down their own volume knob, that consistent, personalized therapeutic relationship, that continuity, might matter just as much, if not more, than the sophisticated diagnostic workup or the niche pharmacological expertise.
Which really leaves us, and you, the listener, especially those of you in healthcare, with a pretty profound question, doesn't it?
It does. It makes us ask, how can we fundamentally redesign primary care models? How can we better equip and support primary care teams to deliver and coordinate these complex, time-intensive, but utterly essential non-pharmacological strategies that are the bedrock of managing chronic, centralized conditions like fibromyalgia effectively over the long haul?
A crucial and definitely provocative thought to mull over. Thank you for joining us on this deep dive, as we've hopefully illuminated the measurable neurological reality of fibromyalgia and reinforced just how vital validation, patient partnership, and truly comprehensive, personalized, continuous care really are.